Um, and then, the heart-brain connection or the brain-heart connection is a two-way street. But I believe Dr. Kishan Patel is going to talk about sort of the heart's impact on the brain when he gives his talk, which I think is later. And, in my readings of the brain-heart connection, something that really struck me was there's a real history to this. And I thought it would be sort of interesting to walk through, where we began to discover this connection and sort of how we led to our understanding of it today. And so the first sort of mentions of this brain-heart connection was really back in the 1940s when there was a physiologist at Harvard named Walter Cannon, and he noticed that people could die just sort of suddenly, and he postulated that they died from fright. And he thought this sort of process, this event, was mostly isolated to people who were superstitious with unrestricted imaginations. And he thought it maybe had to do something with the sympathetic adrenal systems. And he titled it the voodoo death. So, and what kinds of events led to this voodoo death? So they were beginning to catalog these events, and they would include things like sudden death, or collapse of someone close to you, acute grief, loss of someone close to you, an anniversary or a mourning of that event, some event that led to loss of status or self-esteem, personal danger, et cetera. And they even found some cases of people when it was a happy event. And then he had a student about a decade later named Kurt Richter maybe, who decided he would do some experiments to see if he couldn't better understand this process that was described by Cannon. And so this poor guy took a whole bunch of rats and induced, I guess, stress in them by clipping off their whiskers so they really couldn't use it to know where they were. And then would put them in various environments. And then he found that there would be large death within this group. And it was always associated with a profound bradycardia. And so he concluded that Cannon's sort of postulations that this may be related to something with the sympathetics and adrenal system was correct. And he thought it had to do with increased vagal tone because of the bradycardia. And so people continued to be interested in this, and they continued to catalog sudden death. And a lot of the data was coming mostly from EKGs, and this sort of went on into the 1950s and 60s. And so this guy Breyer looked at EKGs of people under severe stress, meaning physical and emotional stress, and he found that they had all kinds of EKG changes. T waves were large, prolonged QTs. He then went on to induce these EKG changes in dogs, and he found that they actually could result in loss of cardiac tissue, so subendocardial ischemia. And then Levine, also in the 1950s, 60s, noted that patients in subarachnoids tended to have these huge changes in their EKG. And this is up here in the upper corner is an example of EKG changes in someone who has a subarachnoid hemorrhage. And you can get T-wave inversions and ST elevations, LVH, as well as a lot of other changes, arrhythmias like AFib and flutter. Birch et al., he went on to show that in 17 patients with bleeding strokes, be it subarachnoids or intracerebral hemorrhages, at autopsy, those who had no coronary disease, if you went back and looked at their EKG changes, found that they had long QTs, large inverted T waves and U waves. So we began to say, yes, these physically stressful events led to EKG changes. And then we could deduce it, both ischemic changes as well as sudden death in animals. So going into the mid-1960s, we began to actually see this in humans, and we were able to show in 3 patients that had subarachnoid hemorrhages that had EKG changes, that when you looked at their hearts in autopsy, they actually had subendocardial petechial hemorrhages similar to those dogs that they did the experiments on earlier. And this was the sort of first time that we were able to say, look, these brain injured patients have subsequent visceral injury, and we think this was mediated by the brain event. Since then, we've had numerous cases sort of reproducing this finding that you could have a brain event that led to actual visceral injury. So it was then, we sort of postulated, how did this happen? Well, there's this thought that there's this dramatic rise in systemic pressure, we think mediated by norepinephrine, and this led to tachycardia arrhythmias. And then as a result, you get this rise in ventricular pressure in parallel to the systemic pressure. And then you have this huge increase in coronary blood flow that leads to injury. And that's sort of how they thought that this injury that we're seeing in the subarachnoid hemorrhages with the subendocardial petechial hemorrhages, how that happened. Other theory that sort of came about is something called the calcium paradox, where you get this massive catecholamine surge, and you get this contracture as a result of that norepinephrine, and then you get this enzyme release and this influx of calcium that causes arrhythmias. So those are sort of the two mechanisms that they thought was leading to the sort of the detrimental outcomes from sort of brain-heart connection. So where in the nervous system does this originate, this sort of response that leads to this catecholamine surge? And so this I found to be a very confusing picture. And in my readings of where does this originate is also, in my opinion, sort of confusing, because it doesn't really localize to one area. It's not like, weakness or numbness or, vision. I mean, it's sort of like this very complex interplay between multiple areas in the brain. And as soon as they think they figure out one thing, they sort of seem to be able to disprove it, because not everyone gets that. But the things that sort of come out often is the insular cortex seems to be a big player in the brain-heart connection. The insular cortex is sort of right here in the yellow area, and it's sort of mesial temporal lobe, and there's a right one and a left one. And the right insula seems to be the bigger player in this, but it can happen with the left insula as well. They think that maybe the right insula has to do more with sudden death, tachyarrhythmias, and decreased heart rate variability is sort of what's attributed to that. But you can get left insula, you can get bradycardia and depressor response as well. So hard to say. The amygdala, which is sort of like your part of your sort of limbic system and your emotional control center, seems to play a role as well, which makes sense because we're talking about stressor and emotions. And then there's parts of the brainstem, mostly the rostral medulla and the solitary tract nucleus, that seem to be also playing a role, and they think that has to do with the autonomic tone. Hypothalamus, because as we all know, that's part of the sort of the neuroendocrine system, so that would make sense it's going to be involved in a sort of a stress response. And then, even though this isn't the brain, there's also some parts of the spinal cord that can also affect sort of the sympathetic systems as well. So summarizing this whole process was this sort of table where you start with some kind of brain event, can be even maybe a mind event, like an emotional stress event. I'm trying to think of an example now that wouldn't be necessarily a brain event. Maybe like the loss of a loved one, causing an increased stress. You get this sympathetic surge. You get all of these catecholamines released, and it can be both the brain mediating the adrenal glands or the brain actually releasing it itself, and then this acts on the heart, and then you get this change in the calcium channels, and then you get this sort of either EKG changes from the calcium, or the catecholamine surge itself can cause wall motion disorders, and this sort of leads to this sort of side box, the sudden death and takasubas, which we're going to talk about. You can also have the sort of the same thing as an exogenous catecholamine, like cocaine, that can sort of cause the same effect. And so talking about sort of sudden death and takasubas, those are the two things I sort of want to focus on now. So sudden death. So the mortality rate of subarachnoids, we used to quote around 50%. I actually think it's less now, but that's still sort of what's tossed around in the literature. And the majority of those people actually end up dying out of hospital. So, and they're just later found to have the subarachnoid hemorrhage as the cause of their death. If they looked at this huge group, I think it was over 6,000 people who had out of hospital deaths, and they looked at their autopsies, about 0.34% ended up being subarachnoid. So subarachnoid, it's a relatively rare stroke if you look at stroke as a whole group. But it definitely leads to death, not infrequently. Other types of neurological conditions can also lead to sudden death. There's Parkinson's and dementia, and there's a high rate risk of sudden death with both Parkinson's and dementia, thought to be related to arrhythmias. And then there's epilepsy, which is not we definitely see it. We see it not infrequently. And there's a 2 to 3-fold mortality increase compared to the general population in people with epilepsy. And they can die from accidents, like car accidents, having a seizure while they're driving, or boating accidents, drowning. There's also death associated with status epilepticus. And then the last thing, which is what I want to talk about a little bit more, which is sudden unexplained death in epilepsy. There we go. So sudden death in epilepsy. So we define this as a sudden unexpected death in a person with epilepsy who has an autopsy, a complete autopsy and toxicology, and they cannot find another explanation. So this is a definite diagnosis of sudden death in epilepsy, or SUDEP, and someone who goes through and has the autopsy and the toxicology. If they don't have autopsy and toxicology and they still don't have another explanation, they call it a probable SUDEP. And then a possible SUDEP is if they do the autopsy and they say, well, there's other confounders or things that could have contributed to their death. And then a near sudden death in epilepsy is when they have an arrest and they're brought back, so they don't actually die, and that's called a near SUDEP. So, how frequent is this? So it's about 1 in 1,000 person years in someone who has chronic epilepsy. And so, and this rate increases in people who have medically refractory, poorly controlled epilepsy. And that's 1,000 person years. So, say everyone lives to 60, that's 1,000 divided by 60 is what's the incidence? Well, that's how many years they've suffered with epilepsy. So it's a little hard. That's how they talk about it, but anyway, it's sort of hard to translate that into how many people will actually have this happen to them. And it occurs more in young medically refractory epilepsy patients, which would make sense based on what I said prior. So what is the pathophysiology? Like, how does this happen? How do epileptics die of sudden death? There's sort of two ideas, and I think that maybe both occur. So seizures can lead to autonomic changes, and you get this increased sympathetic outflow, which then leads to malignant ventricular arrhythmias, or asystole. So sort of that catecholamine surge that we've talked about, that happens. And then the other possibility that people talk about is positional apnea, sort of similar to a SIDS event. And the reason why they think this may be happening is because a lot of people are found prone in bed, and this is more likely to occur in sleep. So risk factors for sudden unexplained death in epilepsy is they have to have generalized seizures greater than 2 a year. So again, that's that medically refractory. They're still having seizures despite medications. They tend to have nocturnal seizures, again, sort of happens more at night. Early age at epilepsy onset. So they've been having seizures for a long time. They're treatment resistant. They've had epilepsy for greater than 15 years. Then there's also sort of increased risk with alcohol use, non-adherence to medications, sleep deprivation, and other substance. So this is a real thing that we probably don't talk about nearly enough. I usually use it when I'm talking to epileptic patients who are non-adherent with their medications. So going back up here, so sympathetic storm can lead to these catecholamine, calcium channel irregularities, sudden death we've talked about, and then there's Takotsubo's. So Takotsubo's cardiomyopathy. So this is also known as stress-induced cardiomyopathy. It was first described in Japan in the 1990s, and it is characterized by transient systolic and diastolic left ventricular dysfunction. And the reason why they call it Takotsubo's is you can imagine, see this sort of octopus in this sort of tsubo, which is, I guess, the pot that they catch the octopus in. So it's octopus pot. And so here's some examples of this and why they call it Takotsubo's. So, and there's various types of Takotsubo's, meaning it doesn't always look the same. This is sort of the classic, the one on the left is sort of the classic example. And the picture on the top is in diastole, and the picture on the bottom is in systole, where they're actually contracting. And it does sort of have that classic appearance. And so it can be apex predominant, it can be mid-ventricular, or it can be base. And that these are sort of the sort of showing the range of Takotsubo's anatomy. So who gets Takotsubo? So women more than men. Usually women with a mean age around 66, so in their 60s. You can have emotional triggers causing Takatsubos. You can have physical triggers, and there's a proportion of patients who have no evident trigger. So, they're saying here that the emotional triggers are not as common as physical triggers, but to me, it's about a third, right? So about a third have emotional trigger, about a third have physical triggers, and about a third have no evident trigger or clear trigger. And physical triggers being things like strokes, subarachnoid, status, and so on. So looking at Takotsubo's cardiomyopathy versus acute coronary syndrome, in patients who have neurological or psychiatric disorders, those patients are more likely to get Takotsubo's cardiomyopathy than an acute coronary syndrome. Interesting, by almost double. If you look at the rates of severe in-hospital complications, including shock and death, they're actually similar between Takotsubo's and acute coronary syndrome, which I think is a little shocking for most of us, because I think most of us think of Takotsubo's as sort of this transient, relatively benign condition that will get better on its own. You just have to support it while they're in the acute heart failure. But to know that there's equal poor outcomes when you compare people with Takotsubo's to acute coronary is sort of surprising to me. And then the rate of major adverse cardiac and stroke events was about 10% per patient year, with about a rate of death of about 6% per patient year. So again, sort of supporting that Takotsubo's may not be this sort of benign condition. So what are the neurological causes of Takotsubo's? We can sort of go back up to that sort of prior table. It's really this, we think it localizes mostly to the limbic system, the premotor cortex, the brainstem, some kind of communication between all of those, leading to a catecholamine-mediated process. Stroke patients tend not to get Takotsubo's, but if they are going to have it, then usually the insula seems to be involved in their stroke. PET scans in Takotsubo patients show sort of increased hippocampal or brainstem activity. And then patients who have higher baseline amygdala activity, so people who live under sort of a chronic emotional stress, are at higher risk for Takotsubo, sort of supporting that there might be some kind of preconditioning to those people who end up getting Takotsubo's, meaning that there are people who are prone to it because of baseline stress levels. And so this is sort of just a picture that sort of shows this relationship. So you get this emotional or physical stressor that simulates the stress or autonomic regions, which, insula is somehow involved. There's sort of decreased activity of the prefrontal cortex, increased hippocampal amygdala brainstem activity. And as a result, you get this sympathetic arousal, inflammation, and then you get Takotsubo's syndrome in the heart. Brain-heart connection. Multiple areas in the brain leading to either this catecholamine-mediated response, which we think is similar to what happens in the Takotsubo's, or some kind of arrhythmia mediated mostly by the calcium paradox, where you get this inrush of calcium leading to arrhythmias. So I'm just going to go through a couple of neurological conditions and then talk about what we see with that neurological condition. And this is all just sort of gee whiz information, I think, just to point out really how strong that brain-heart connection is, because it's pretty frequent that we see cardiac complications in people with neurological injury. So in acute ischemic stroke, up to 90% of stroke patients will have abnormal EKGs. And I think most of us are like, of course, it's all AFib, but no, it's not. It's also AV block, asystole, ventricular ectopy, bradycardia. Sometimes it's transient, just during the acute stroke. Sometimes it may be led up to the stroke and is the cause of the stroke. We also see this elevated troponin and CKMB commonly in people who are stroke. And if you consult cardiology, which I have done numerous times in the past for this, they always are like, this is, demand ischemia, essentially. We don't see a lot of Takasubos in acute ischemic stroke. It's not impossible, but it's just not as common as a lot of other things. So intracerebral hemorrhages also see a ton of EKG changes. 64 to 95% of cases will have EKG changes. Prolongation, ST changes, inverted T waves, bradycardia, AFib. Myocardial injury itself is uncommon, meaning that if you looked at their hearts, they don't normally have those sort of subendocardial ischemic or hemorrhage changes that we described before. You can also get elevated troponin and CKMB in people who are having an intracerebral hemorrhage. Sorry. And we think this is also related to sort of that demand. So in subarachnoid hemorrhages, greater than 90% of them will have EKG changes, T wave inversions, U waves, signs of LVH, prolonged QT, leading sometimes up to torsades, VFib and asystole, sinus arrhythmias, and AFib. Often those occur 24 to 48 hours after their presentation. Myocardial injury in subarachnoid hemorrhages is actually pretty common, like 33%. And this does correlate to the subarachnoid severity score. So if someone has a high Hunt and Hess, they're more likely to have myocardial injury. So who gets Takasubos in subarachnoid hemorrhages? Usually young women. And, you know, Takasubos is reasonably common in subarachnoids. We see it frequently, usually in our patients who are young women. And that people who get Takasubos are at increased risk for vasospasm and delayed cerebral injury. So getting Takasubos is not good. Talk about head trauma. So head trauma, we don't see a lot because we're not a trauma center, but EKG changes are less common, and then Takasubos is also not very common. In the EKG changes you see in head injury tend to be P waves and T wave inversions. Very rare to have myocardial injury associated. More common to get sort of dysautonomia with spinal cord injury. Migraine, which I thought would be something sort of outside the neurocritical care box, but it does support this brain-heart connection, is that, you know, people who have cardiac structural changes are at increased risk for migraines, including PFO, ASD, mitral prolapse. And that you can find PFOs and ASDs in over 50% of patients. And it's interestingly, when they're actively shunting from right to left, they're more likely to have migraines. Still a little unclear the benefit of PFO closure in migraine treatment. And there's also sort of vague, not well defined EKG changes that can occur during migraines as well. We talked a little bit about SUDEP and epilepsy. There's also something called ictal tachycardia, which means when you're having your seizure, you're tachycardic, and that's essentially almost everyone who's having generalized seizure. But you can see it in focal seizures as well, also mediated by that sort of sympathetic system. AFib and aflutter can occur, and then ictal bradycardia can occur in as much as 20% of patients, which honestly is, I thought, interesting. I did not realize it was that common. Parkinson's disease and dementia can cause autonomic disturbances. Orthostatic hypotension is common, as well as QT prolongation, and that may be playing a role in why they have sudden death. So those are sort of individual cases. What about a population group? If you look at a population that undergoes something stressful, the Northridge earthquake is an example of looking at a population that sort of all goes through this very stressful, emotionally stressful event. It happened in 1994. It was in LA. It was a 6.7 Richter scale earthquake. And it showed a 35% increase in the number of admissions with myocardial infarction a week after the earthquake. And so from this event, I guess the cardiologists talk about this a lot when they talk about brain-heart connection. They sort of said, you know, this is sort of was a new concept that myocardial infarction may be related to certain triggers and stress that I guess wasn't recognized as well before. And looking at sort of this population, they felt like maybe the stress perceived by the brain, such as anxiety and depression, and the sort of experience they're going through may be a factor in their active cardiovascular process. And that the stress might be the actual thing that triggers the cardiovascular event. So because we all have COVID on the brain, I said, okay, is there any evidence or anything out there about COVID and the heart-brain connection? And apparently this is a pretty sexy topic now, because there were several articles about it. This was sort of a summary picture that they were putting forth, which I also find very confusing. But what I've sort of brought from this is that, you have, looking over here, you have this sort of viral component where, is the virus itself acting on the brain, causing those parts of the brain that are involved in the brain-heart connection being injured by the virus itself or through microthrombus? And could that be part of how COVID is affecting the brain-heart connection? And then there's also this idea that people are experiencing emotional stress, anxiety, fear, sleep deprivation, etc. And is that also affecting the sort of that catecholamine / adrenal stress hormone sort of component to this? And then you get this autonomic unbalance, increased sympathetic tone, and then you result in Takasubos and or arrhythmias, essentially, is what this is sort of. This is just a very complicated picture to show that. And so really, is it directly affecting the brain centers that have cardiovascular control? Or is it this bidirectional neuronal vascular communications, the words they're using, that potentially lead to emotional stress, anxiety, thus leading to cardiac hypertrophy, Takasubos, arrhythmias? So how do we try to prevent or treat or disrupt this brain-heart connection? A lot of people thought, well, maybe beta blockers, but they've looked at that actually, and they said, okay, look at this population that gets Takasubos. How many of them were on beta blockers? Well, a good portion of them were on beta blockers. So it doesn't appear that beta blockers are necessarily protective. They haven't ever done any randomized trials on this, but I think that's sort of, it would make sense it would help, but it doesn't appear to at this time. ACE inhibitors seem to have some kind of protective role. Again, not very well understood. And a lot of people talk about sort of stress reduction, exercise, improving cardiovascular health and mental health as ways to try to further support this brain-heart connection and prevent these arrhythmias and Takasubos, cardiomyopathy. And then I was going to play another song for you guys, but that doesn't seem to work. And then my references, and then this is Asa, my 3-year-old, on his first day of school. And thanks for your attention. And that's all.
All right, that was great. Thank you, Lilith. Do we have any questions out there? Thank you for such an interesting presentation, is what one of the comments is, Dr. Judd. I'm curious, why do we see Takasubos more with subarachnoid hemorrhages than, say, with other types of bleeds, like subdurals or ICHs?
I think it mostly probably has to do with the hypothalamic involvement, because we tend to get a lot of hypothalamic involvement with subarachnoids. Mm-hmm. Would be my guess. And it's a pretty big sympathetic surge that happens when the aneurysm ruptures. Yeah, it's just a lot more dramatic.